Hello, hi, good morning, everybody. My name is Huanyu Wang. I'm a director of Molecular Microbiology Laboratory at Nationwide Children's Hospital. I'm also associate clinical professor at the Ohio State University. The title of my presentation today is Detection of Human Herpesvirus 6 in Pediatric CSF Samples, Causing Disease or Incidental Distraction. Financially, I have nothing to disclose. I'm going to start my presentation with a case. So this is a 44-days-old baby boy presented to the ED with fever, apnea, and seizure-like activity. On the day of admission, he was in his usual state of health, and parent noticed that he became stiff after feeding, which lasted a few seconds. Then it happened again about 5 times, lasting up to 10 to 12 seconds at a time. At ED, he was positive for fever and congestion. A lumbar puncture and full septic workup was done. He was then admitted to the infectious disease service. Neurologist was consulted who recommended imaging, which were all negative or non-specific. CBC and CSF were unremarkable. Infectious disease workup include blood culture, urine culture, CSF culture, which were all negative. Some PCR were done like B19, HSV1 and 2, and enterovirus were all negative. However, respiratory multiplex panel was positive for enterovirus and rhinovirus, and his CSF was positive for HHV6 on the meningitis and the encephalitis panel. So he was actually doing pretty well, and seizure-like activity was not observed while he was hospitalized. He was then diagnosed with a viral infection due to enterovirus or rhinovirus and discharged home. So what about detection of HHV6 from his CSF? His treating physician thought it was not contributing to the disease and sent his whole blood out for a confirmation testing, which came back, says the HHV6 virus to the cell ratio is approximately 1, which is consistent with HHV6 chromosomal integration of the virus into the patient's cell genome. So today I'm going to describe HHV6 virus, the epidemiology and clinical presentation of HHV6 disease. I'm going to review evidence of clinical consequences of inherited chromosomally integrated HHV6 and talk about how laboratory diagnosis is used for diagnose HHV6 infection. And finally, I will summarize a paper that we recently published on detection of HHV6 in pediatric CSF samples. So this virus was discovered early in 1985. It was isolated from the peripheral blood mononuclear cells of patients with AIDS. And then they found this on the cell culture. Scientists found this unusual cytopathic effects characterized by enlarged balloon-like cells. And electron microscopy confirmed the production of the cells of the viruses. Also found the morphology of these viruses are consistent with herpes viruses. However, the DNA of these viruses did not cross-hybridize to other human herpes viruses. Therefore, this virus was named as a member of herpes viruses and later named as Herpesvirus 6. Until 1988, this virus was etiologically linked to a human disease. So there are actually 2 species of HHV6, HHV6A and B. These 2 viruses share about 88% identical on the level of nucleotides. Along with HHV7, they belongs to genus Roseola viruses and subfamily Beta Herpesvirinae. The virus is about 200 nanometer with 4 major components: a double-stranded DNA, isocathedral capsid, tegumen, and a viral envelope. The genome contains a unique central region that encodes a few open reading frames. And this central unique region is flanked by direct repeats, where it contains sequences that are similar to that of the sequences in telomere of the vertebrates, such as human being. Like other herpes viruses, after primary infection, these viruses can establish a latency and can be reactivated later. Unlike other herpes viruses, the latency is through integration to the telomere region of the host chromosomes. The integration can occur in a small portion of somatic cells and then can be reactivated later. Uniquely, these integration can occur in the germline cells that leads to the offspring carrying the whole entire genome of HV6 in every nucleated cells. So this is really is inherited condition that the entire genome can be passed on to the offspring. It is believed that a couple thousand years ago, in independent events, both HV6A and HV6B were integrated into the germline cells, which results in about 1% of human being, 1% population that carry this genome in their telomere. So the HV6 infection is ubiquitous. Primary infection occurred within the first 2 years of life, peaked between 6 and 15 months with the waning of maternal antibody. The seropositivity in the adult population is now estimated to be 95%. The transmission, contact with saliva is thought to be the main route of transmission. However, vertical transmission can also happen. It can happen during a maternal reinfection with a new strain of HV6 or reactivation of a previous infection. Of course, entirely chromosomal integrated HV6 can also result in vertical transmission from a parent to a child. Organ transplantation of HV6 has been reported infrequently. However, transmission through breastfeeding or blood transfusion has never been reported. Primary infection occur early in life, present as undifferentiated febrile illness in children between 6 months and 1 year old. A subset of these children can present classic manifestation called roseola infantum, also known as 6 disease. HV6 primary infection accounts about 20% of ER visits for febrile children in the United States, and the most common complication is the febrile seizures. Congenital HV6 infection occur about in 1% of the children. However, most of these patients were asymptomatic. Reactivation of HV6 occur mainly in the context of immunosuppression. It can occur in transplant recipient. The presentation is not specific, can range from fever, rash, hepatitis, encephalitis to a variety of transplant-related manifestation. In the immunocompetent individual, however, the reactivation is often subclinical and also in conjunction with other clinical conditions. Since the discovery of this virus, it has been linked to CNS disease. Febrile seizure, as mentioned earlier, is the most common complication in the primary infection in infants and young children. The HHV6 DNA can be detected in some of these from CSF in some of these children. Encephalitis, HV6 encephalitis is a recognized complication following transplantation, especially stem cell transplantation. Most common manifestation is acute limbic encephalitis. These patients often have poor outcomes with high mortality and also a high likelihood of neurological sequela among those survivors. It is also associated with progressive multifocal leukoencephalopathy and multiple sclerosis. As we mentioned earlier, that 1% of a population carry HHV6 in their genome in every nuclear cells. The question is there any consequences or is there any risk of health consequences? Although it has been thought that integrated HV6 is stable and is inconsequential, but there are some evidence suggests that they are not very stable. So first of all, it was found that ICI-HV6 can be activated in vitro when treated with this compound known to reactivate latent herpes viruses. Also, a study found that moms who are positive for ICI-HV6, meaning they carried HV6 in every nuclear cells, can transmit HV6 to the newborn at birth while the newborn did not inherit HPV6 from the mom. Also, there is a case that found that reactivation of ICI-HV6A in this patient with severe immunodeficiency has led to the infectious virus and was also associated with the disease in this patient. The evidence include that HV6A RNA was detected, which suggests active infection, and the virus was isolated from this child mononuclear cells. And finally, patient responded to anti-HV6 treatment. In addition, there are some small studies found that there might be association between the ICI-HV6 and the increased risk of complication in transplant patients. So how HV6 infection is treated? Currently, there is no antiviral agent or immunotherapy has been specifically licensed to treat or prevent HV6-associated diseases. There is no randomized clinical trial exists for treatment of HV6 encephalitis, and the duration of treatment is not clear. Dalzaclavir and fosfoconazole has antiviral activity against HV6B. However, there is insufficient evidence of their value treatment against HV6 encephalitis in patients with transplantation. So what is the laboratory diagnosis role in diagnosing of HV6 infection? Primary infection is often diagnosed clinically. Laboratory confirmation is not required. However, really is the transplant recipient in the concept of reactivation sometimes require laboratory diagnosis to help to provide proof of HV6 infection, to define the status of HV6 infection. Is it active infection, or the detection of HV6 is due to latency or ICI-HV6? Finally, diagnosis of HV6 CNS infection require a laboratory confirmation. So serology has been used to document previous infection. Currently, there are assays available for detecting HHV6 IgM and IgG. However, the utility of serology here is limited because these assays cross-react with other beta herpes viruses, and also there is delayed or altered response among those transplant patients. Nucleic acid amplification tests that detection of HPV6 DNA can provide proof of HPV6 infection and is commonly used. Most of these assays are laboratory developed tests. To determine active HPV6 infection can be challenging. Viral culture is the reference method to provide evidence of infectious virus. However, this type of testing is labor intensive. It's really not commonly available. Antigen detection using IHC can also provide evidence of viral gene expression. However, the sensitivity can be an issue. Again, nucleic acid amplification tests are commonly used to quantify the viral DNA. Increased or high viral loads may suggest active infection, but there is no international standardization. Therefore, results from different laboratories cannot be compared. And also, clinical thresholds for active infection has not been established. Finally, in the case of ICI-HV6, these individuals can have high viral loads in the whole blood and in the tissue. And again, these type of testing are mostly laboratory developed tests. Also, the testing HPV6 mRNA can provide evidence of viral gene expression, but used in the research setting. So how to determine a CNS HPV6 infection? Again, it can be challenging due to the non-specific presentation. And detection of HPV6 in CSF alone cannot establish laboratory cannot establish the diagnosis. Currently, in order to diagnose HPV6 infection, CNS infection in transplant patients, it requires the presence of CNS symptoms, the absence of other identified cause of CNS dysfunction, as well as detection of HPV6 DNA in the CSF. Currently, there is one FDA-cleared test that can detect HPV6 from clinical sample. It is called Pulmonary Meningitis Encephalitis Panel, which we will discuss a little bit more later. So how laboratory detection of ICI HHV6? Fluorescent in situ hybridization has been used to not only detect the ICI HHV6, but also locate where the integration site of ICI HV6. Here I'm showing you the T cell culture from family members who are positive ICI HV6. The green dots are the HV6 probe, and the red dots probe the telomere sequences, and you can see that the ICI HV6 was found in the same chromosome telomere of the father sibling and the siblings, really demonstrate germline transmission. Detection of HV6 in higher cell-free samples such as hair follicles, fingernails, or skin cells only occurred in ICI HV6. Therefore, this can be used to diagnose ICI HV6. Currently, there is one laboratory in the United States that offers this type of testing. Droplet digital PCR that can calculate the ratio of viral copies and cellular DNA copies. Any ratio close to 1 or higher than 1 is suggestive of ICI HV6. This testing is available at reference laboratory, which is also the one that we used was used in the case that I presented earlier. For those who don't have access to digital PCR or specific testing in fingernail or hair follicles, viral loads in whole blood can also provide a clue. HV6 level in whole blood that exceed 10 to the 5.5 are strongly suggestive ICI HV6. So these high level is consistent with the number of nucleated cells in the whole blood. However, caution should be given those individuals whose whole blood cell count significantly decrease, and especially in the transplant recipient. So currently at Nationwide Children's Hospital, we offer a laboratory-developed real-time PCR to quantify the viral loads in CSF, plasma, and whole blood. We also use this laboratory-developed test PCR to provide qualitative result for detecting HHV6 from tissue. From March 2021 to March 2024, we performed 2,800 PCR, about 900 a year. The positivity rate is very low. It's only 3.6% were positive. Majority of these orders were from transplant patients, and the rest of them were mainly from infectious physician. We also offer this Filmary meningitis encephalitis molecular panel that detect 14 common pathogens that cause meningitis and encephalitis, and HHV6 is on this panel. Since the implementation in September 2017 to March 2021, we performed a little over 2,700 CSF testing on CSF, and surprisingly, HHV6 was the second to most common detection on this panel. So really, we are testing every CSF for HHV6, which present a diagnostic dilemma. Detection of HHV6 in CSF can be the cause of infection. However, you can also detect viral latency or subclinical reactivation not contributing to the disease, as well as ICI HHV6. So therefore, we conduct a study trying to understand the impact of HV6 detection by molecular multiplex panel from CSF in pediatric population at Nationwide Children's Hospital. So we aim to determine the prevalence of inherited chromosomally integrated HV6 in our patient population. We also compare the clinical and the laboratory characteristics in children with and without ICI HV6, and also among those children with and without HHV6 infection. So during the study period, we tested 2,700 CSF. 65 patients were positive for HHV6, which make the prevalence 2.4% in our patient population. 3 patients didn't have clinical data available for review, and 3 patients didn't have remnant specimen for additional testing. These 6 were excluded which left 59 study subjects. We perform a research use assay to determine if the patient is positive for ICI-HV6. We also review the medical chart of these patients, and these, according to the physician notes, each patient is assigned to one of the 3 categories: HV6 infection with CNS involvement, HV6 infection without CNS involvement, and detection of HV6 is incidental finding. We also collect standard of care laboratory results. And in addition, we quantified viral loads in 53 CSF, 51 plasma, and 27 whole blood from these patients. So the median age of this cohort was 5.5 months. Half of these patients were male. We found that a little over half of these patients were normal hosts, older than 60 days. 3 were immunocompromised, and 25 patients, 42%, were infants evaluated for sepsis. When we look at the clinical characterization, about more than half of these patients, in the detection of HPV6 is an incidental finding. Less than 30% of these patients had HPV6 infection with CNS involvement. 23 patients were positive for ICI-HV6, which makes the prevalence of ICI-HV6 in our patient population about 0.85%. So now when we look at the individual that were positive for ICI-HV6 and negative for ICI-HV6, we found that individuals that are positive for ICI-HV6 were significantly younger, with a median age of 0.9, less than 1 month, compared to 8.5 months in non-ICI-HV6 group. And these patients were less likely to present fever, and we found no difference in the other clinical manifestation like rash, febrile seizure, neurological symptoms, ICU admission, as well as length of stay. When we look at their laboratory results, the viral loads in CSF and whole blood were significantly higher in the ICI-HV6 group compared to non-ICI-HV6. And then, however, the median viral loads in plasma were no different. When we look at this 11 patient who the viral loads of 11 ICI-HV6 positive patients, 9 had a viral load greater than 1 million copies per ml. 1 patient was neutropenic at the time of testing, therefore the viral loads in the whole blood was much lower. And among these 16 whole blood viral loads in non-ICI-HV6 group, none of these viral loads was higher than 1 million copy per milliliter. And we found no difference in the CSF analysis, and the co-detection with other pathogens on the panel were seen in both groups. And when we look at the disease correlation, interestingly, infant evaluated for sepsis account majority of patients in the ICI-HV6 group, while normal host account majority of patients in the non-ICI-HV6 group. 91% of patients in ICI-HV6 was classified into incidental finding group, and 2 patients in this group were thought to have infection with CNS involvement by the treating physician. So these are a 14-day-old baby admitted for fever with CSF cytosis and rash, and a 1-year-old child with febrile seizure and rash. So in these cases, it could be a reinfection of another strain of HV6, or these patients had an infection with other viruses that we did not detect. In the non-ICI-HV6, 66% of these patients had HV6 infection, either with or without CNS involvement. And 33% in this group were thought to be incidental finding. Now we look at we looked into the non-ICI group, ICI-HV6 group, And we found that HV6 infection without CNS involvement, these children were much significantly younger, and also majority of these children were infant evaluated for sepsis. When we look at the viral loads, we found that the viral loads in CSF plasma as well as whole blood were all significantly higher in HV6 in HV6 infection groups, either with CNS involvement or without CNS involvement. That suggests that in the case of infection, the virus is actually actively replicating in these cases. And we find a protein in the CSF protein was higher in incidental finding group, and also pleocytosis was only seen in the incidental finding group. Among these 12 patients, 10 patients had CNS disease diagnosis. So really, when we look at our finding by patient groups, 31 were normal hosts older than 60 days. The median age was 14 months, and majority, half of them had HV6 infection, and 45 had CNS involvement. Only 20% of these patients had was positive for ICI-HV6. And then 3 patients were immunocompromised, and 1 patient actually had HV6 encephalitis and was treated for HV6. Other 2 patients were positive for ICI-HV6. And when we look at the 25 baby evaluated for sepsis, only 8% had CNS involvement related to HV6 infection, and 60% of these patients, the detection of HHV6 was due to ICI-HHV6. So the key finding of our study include that ICI-HV6 was detected in 40% of HV6 positive CSF. The prevalence is 0.85% in this patient population. High viral loads in whole blood suggest ICI-HV6, and these patients are less likely to have fever and much younger, mainly babies. And in 91% of time, HV6 did not contribute to the presentation. In non-ICI-HV6 individuals, higher viral loads discriminate between true infection versus incidental detection. So in our cohort, CSF detection of HV6 was associated with CNS disease only in less than 30% of these patients. So to summarize this presentation, HV6 is a common pathogen in young children causing febrile illness. It is also an important pathogen in transplant patients. ICI-HV6 is stable and benign. However, growing evidence suggests that ICI-HV6 can cause disease and may be a risk factor in immunocompromised individual. ICI-HV individuals demonstrate high viral loads in whole blood. And finally, detection of HV6 in CSF from pediatric patients should be interpreted with caution. It may represent the cause of presentation or incidental finding. With that, I'm gonna thank to my Dr. Amy Lieber, Dr. Sofni Oyeniev, my 2 other directors of microlab here at Nationwide Children's Hospital for their critical review of these slides, and also Dr. Christina Tomatis, is the infectious disease physician here at Nationwide Children's Hospital. And thank you everybody for your attention and time.